Hey, Perry. Can you hear me okay?
Buttons here. Good morning, Rich. Good to see you. How are you?
All feeling good. We had our Cannabis Regulators Association meeting last week up in Washington and had a good visit with other state regulators. And as you know, this group has not been around a long time. We're brand new. And so there's a lot to share, a lot of good topics, a lot of good connections and learning going on between each other. So it was good.
Great. How many people showed up?
Oh, goodness. We had like an external meeting where we had federal people from federal agencies present, and we also had people from different associations and companies present. And that was a pretty good sized group of, I'd say, 200 to 300. And then down in Olympia, we had a smaller group get together that was more like about 130 or so.
I'm kind of curious, you know, with people speaking about from the federal side of things, what's a sense of how do they reconcile these state programs with the drag from Congress in terms of legislating anything that would change the Controlled Substances Act to prevent the conflicts that obviously exist between federal regulations and state programs?
How do the feds feel about the states doing what we're doing?
Well, they're in a awkward position. Everybody's in an awkward position. I'm just wondering if anybody's actually speaking about that out loud rather than just sort of, pretend, flying under the radar.
What the federal groups have done is they have reached out to the states for guidance and for a lot of input, and especially like state regulators, because we're the people that have been on the ground with this industry, allowing them to work under state laws, trying to keep it legitimate. And so they reach out to us quite a bit, actually, not specifically me, but to the leadership of our association, for our insights about how to appropriately regulate this industry. And so that's been good. They know we have a very unique position where it's been against federal law, but it's been legal under state law. And so regulators have learned a lot about what works and what doesn't at the state level, I think. And they're looking to replicate, if it does come through with Congress, they want to be prepared at the federal level in the agencies to be able to have a robust system that can still keep people safe, but has some testing, has a robust testing component that helps these companies ensure that their products are safe and that the public is still, kept safe, and it's not just treated like a regular product, but it's still treated like in medicine. But then they understand that a lot of states don't treat it like medicine; they treat it like a food. So,
all right. Yeah. Well, I see that. Well, thank you. I was just curious how that reconciliation is going, and if there's any word on decriminalizing, or if it's just sort of.
There is now more than ever. I think what would probably happen first would be the Safe Banking Act, and that would just make it so the businesses can transact normally and bank their money and not have to, use only certain credit unions or they make it so they don't have to rely so much on cash.
All right. Well, we could have a lot more talk about that. Maybe if we've got a little bit of time at the end, we can maybe have you give us some high points from that. In any case, it's 9 o'clock. we're going to get started. I'm going to bring the monthly meeting of the now known as the Utah Cannabis Research Review Board meeting to order under the new and reformed, if you will, reformed Health and Human Services Department, under which the Center for Medical Cannabis now exists. So there's a sort of a restructuring, reorganization. I want to just start by acknowledging our new very important staff member and Chief of Compliance, Sarah Lelos. Am I pronouncing that correctly? Your last name?
That's
Thank
correct.
you, Sarah. Sarah, and Shara's going to now share her screen with the intro slides that, as you've become familiar with me going through this, but this is just a pro forma bit of importance. And I do believe before we get started, I want to make sure we have our quorum of board members. So I've got myself, I got Dr. McGiff, Dr. Norris, Dr. Carlson, Dr. Moss, and welcome Dr. Moss, whose first official meeting. Thanks
Thank
for
you, guys. Glad to be here.
And Dr. Zender. So we clearly do have, and Dr. Heath, who's will be, well, we'll talk a bit more about Dr. Heath in a moment. In any case, we do have a quorum. So this meeting is held, as you obviously know, virtually and hosted by the Utah Department of Health and Human Services and Center for Medical Cannabis based here in Salt Lake City. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared of this meeting, and approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. So that's our major formalities. I want to review, it's I think always important, and we've sort of discussed this frequently and decided as a group that it's always important to review why do we exist? What's our raison d'etre, as it were? And of course, we do have a requirement under the legislative act to follow these our bylaws. But our purpose is to review the available research literature and assist the Department of Health and Human Services and the Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualified medical conditions. And of course, this is a very broad-ranging mandate that includes both looking at effectiveness, efficacy, and safety, sort of both sides of the coin, to create a balance that that keeps both individual health and public health in mind. Next slide, please. I'm pleased to again welcome this transition into our new, our year begins July 1st. So this is the last month of our of this sort of session, if you will, of the 1922 21-22 year. This will be my last meeting as the board chair. We will have a new leadership beginning July 1st, and we'll talk about that in a moment. With us today and on the board is Dr. Catherine Carlson, Brian Zender, Misty Smith. I'm trying to see if Misty is with us today. I do not see Misty. Please speak up, Misty, if I've missed you. Okay. Dr. Jennifer Norris is with us. Dr. McGiff and Dr. Michael Moss is with us. And Michael, I'd rather than me, why don't we get an opportunity to hear your voice? And I'm going to sort of take a little brief cut from there and let you introduce yourself and your role. And I'm going to be speaking a little bit more about you as the meeting progresses, but let's get a chance for everybody to see you.
Yeah, sure. Thanks, Dr. Fine. So glad to join the board here. My name is Mike Moss. I'm medical director here at the Utah Poison Control Center, where I'm sitting right now, which is in the College of Pharmacy at the University of Utah. I also work shifts in the ER at the University of Utah. And then I also do some inpatient addiction medicine. So we're a couple different hats. So my view on cannabis kind of spans all three of those pieces, from acute adverse effects of patients using too much and coming to the emergency department, more from the public health standpoint of what happens when children or other adults that weren't intending to get a cannabis product accidentally take it, and what sort of side effects or drug interactions might patients take that are using cannabis for medical purposes. What about the driving end when we talk about the ER and motor vehicle collisions? So safety and adverse effects is kind of my jam as far as cannabis and toxicology goes. And of course, I like everything about drugs and how they work as a toxicologist. So hopefully I can give some input kind of on that realm of things to the board. And I've been long interested in this and have worked bits and pieces with people over the years since this has started. So glad to be more fully involved this way.
Well, great. We're both delighted and honored to have you, and thank you for volunteering your time to this effort. It's greatly appreciated. And while we're sort of on that theme, Dr. Heath, Lauren Heath, is with us. Lauren, can you show yourself? And there you are. And Dr. Heath, I want to celebrate you for your tremendous service over the last few years as a board member. But now you've transitioned to an equally important but a different role in supporting the research efforts that are obviously a big part of what this board is about in a very more formalistic way. And I'd like you to maybe just make a comment or two about that role. And Rich, of course, if you want to, and Sarah Ponce, if you want to make a word or two about Lauren's role. She's already contributed greatly, and before even this first meeting, and we'll hear about some of her efforts in a moment. But Lauren, sort of reintroduce yourself, if you will, to the group in your new role.
Sure. Thank you, Dr. Fine. My name is Lauren. I'm a pharmacist that works at the University of Utah College of Pharmacy in the Drug Regimen Review Center. The Drug Regimen Review Center wears a few hats, but we have expertise in conducting systematic reviews to help inform evidence on various topics. And so I'm happy now to be in this new role where I can lend some of that expertise to helping the Utah Cannabis Research Review Board in identifying relevant evidence to help address their charges. So I'm happy to be in this role. Thank you.
Great, and we are absolutely delighted to have you in this role. And it's been a long road to get the funding and the appropriation and the designation for this role. Up until this point, just to remind those who are on the on this meeting and those who might check in with it later, up until this time, most of the librarianing, if you will, and the research has been done by members of the board on a voluntary basis, and everybody, wears multiple hats, and so it's really been a challenge. But we've made it through this point and have, I think, really enriched the portal, the web portal, with a lot of information about cannabis with intended medicinal use. And I think going forward, we're going to greatly accelerate that and do even more justice to the role that we've been assigned by the legislature, and to help inform the legislature, and as well as others who have a stake in all of this. So thank you. And I don't know if Rich or Sarah want to add anything to that, or we'll just move on. Okay. With that, I do want to, I see that Misty Smith has joined, and so we're not losing our, if you will, essential pharmacy connection with Lauren's moving off the board. Misty came onto the board a few months ago and has already been a very valuable contributor to that. And pharmacists play a very important role in the program. And so having that connection formally is very important. I want to acknowledge Dr. Michelle Hoffman as the in her role as our sort of medical connection to the center and to the department. Rich Oborn, who will know as our executive director of the program since its inception. Sarah Ponce, our senior registered nurse and research manager, who is enormously helpful in keeping us going. And then, of course, Sarah Lelos, who's now joined us. So that's sort of the team moving forward. We welcome any visitors to our virtual meeting at this time. I do believe everybody that I can see has a name attached to them. If you are just on the phone, please let us know who you are. There will be a public comment period that we've always respected at the end of the scheduled agenda. We're trying to allow at least 15 to 20 minutes for that. Select the raise your hand function appearing at the bottom right of the screen, and we'll do our best to call on everybody and accommodate you. We'll try to adhere to a fairly strict structure so that everybody has a chance to weigh in. That pretty much does it. Let's go to our last slide. I think this may be
That is the last slide.
go to the agenda then. Thanks, Sarah. Great, there we go. So the first order of business is to approve the April minutes. We took a month off last month to rest and recuperate after a very busy legislative session and other things. But we do have April minutes to approve. If I may have a motion.
I make a motion to approve the minutes.
A second.
Okay. If there are any objections, I would like to hear them. Otherwise, we'll assume by a claim that the minutes are passed. Hearing no objection, the minutes are approved. So we're going to start this meeting with if Jess is ready, have Sarah Ponce sort of lead this section. We've taken on this project again. If those who have been on calls previously, you know of this. As we've reviewed, now that we have 13 pharmacies, is that right, Rich? 13 registered pharmacies under the program.
There's 14.
Now 14. We grow almost quarterly,
and there'll be 15 by the end of the summer.
Okay, so we've almost doubled since a year ago, and with that, there are well over 1,000 products that are now available through this program that those holding cannabis cards can purchase. It's, as we've reviewed and met with a number, these entities, we realized that we really have a responsibility to understand what actually is out there, especially in terms of formulations, doses, combinations of different cannabinoids. We have I think a very strong sense of safety from the standpoint of knowing that these products through the agricultural side and toxicology side are being evaluated for purity and make sure there's no they're not tainted in any sort of way, as well as measuring increasingly which cannabinoids are in these products, and those are by law have to be listed and so forth. But in terms of dosing and dosing recommendations and closing the gap between the evidence base and the guidelines that that we're creating, along with national and international consensus guidelines for cannabis use as a medicinal agent, we want to understand and allow qualified providers as well as additional providers who are recommending cannabis to be able to be more specific in making the recommendations about dosing in conformity with best evidence. And we realized there was a big gap there. So with that, we've initiated this project to try and determine not only what's out there, but to create a listing of what those products are and what those formulations are. Sarah Ponce, if you want, please provide some additional background, and then we'll sort of review our findings to date.
Yes. So as Perry mentioned, the initial idea was to identify what products we had and write a list to recommending providers and PMPs, the pharmacists, to
Sarah, I'm sorry, your microphone is a little echoey for me at least. It might just be me, but it's a little hard to follow you.
I'm sorry, I don't know. It's just the computer microphone. Let's see. Is it still echoing?
It just sounds like the quality is really off or something. I don't know, connection or otherwise, but I'm kind of hearing the same thing.
Yeah, I think we can make do. I can make it out. It's a little echoey.
Yeah, we can make it out. It just sounds different than you typically do, Sarah. That's all.
Let's see if I can switch to earbuds. Is this any better? Okay, great.
Yeah.
So what the initial plan was to be able to provide a list and with the cannabinoid profiles so that recommending providers could be able to recommend medical dosings to their patients. And what we found when we were going into our database was that we were missing a lot of pieces to be able to provide this information. We were missing how patients are actually using these products and what the recommendations by the PMPs or the QMPs were to the patients. So it was really hard for us to make a determination just strictly based on the total product THC as to what the patient was actually taking. And so what we're going to do now is take this information and hopefully provide guidance to the Health and Human Services in November with our report to let them know where the communication gaps are between the PMP, the QMP, and the patients, and provide recommendations on how to close those gaps so that the providers can understand what their patients are taking and how they're using the products, and we can better understand how these products are being used and for the specific qualifying conditions. And so we're going to request that these conversations and recommendations from the PMPs are either written down for us to be able to obtain them either in the system or on a separate piece of paper for the patient, and so that everybody can close that loop of communication. And so this presentation that Jesse is going to present is mostly on purchasing trends and overall product trends, but not necessarily on how the patients are using the products. Thank you.
Okay, then I'll go from here. Can everyone hear me?
Yes.
Yeah.
Good, Jess.
Good. Okay, just to start with, looking at cannabinoids in the pharmacy program, there's a decent number of limitations. The first one is we're dealing with natural compounds. These aren't lab synthesized, so there's going to be a decent amount of variation in the amount of, say, THC, CBD, and other cannabinoid concentrations in products. This could be caused by growth inputs, differences in harvesting and processing, collecting and processing the plants, solutions separating out after they're processed, and differences in the decarboxylation process, which is converting cannabinoid acid forms into their psychoactive or medical cannabinoid equivalent. So changing CBDA to CBD and THCA to THC. And then, as Sarah already mentioned, what we have is sales, not use at the moment, based off of the data we have. It's possible that there can be a lot of things kind of left out when you're looking at sales data and trying to equivocate it to medical information. There is a decent chance that patients may be compounding medical cannabis products, say taking an over-the-counter CBD medication alongside something purchased at a pharmacy, for instance. And then, as Sarah also mentioned, we don't have much documentation on individual dosaging per week for patients or documented PMP use recommendations. Next slide here. The next large issue that we have is kind of just a lack of general research. Hopefully this is going to change moving forward, but just because of the federal illegality of cannabis, there's still a whole lot of limitations on research at the moment. We also have a lack of many consistent measures across product types, both within cannabis-based products. Say, it's kind of hard to equivocate the medical use of, say, a cartridge versus an edible or a flower. And then it's also kind of hard to equivocate the, say, medical use of any of those cannabis products versus something outside of that, say, an opiate. A lot of that research is still kind of on the way. And then, of course, as we all know, there's a lot of claims that go around about properties of cannabis. And we just don't have a lot of research completed yet to prove or disprove a lot of those claims at the moment. Let's go next here. This is a quick chart just showing the breakdown of sales per subcategory. So as you can see here, flowers are the most popular product. They sell the most, followed by cartridges, then gummies. And then everything else kind of tends to sell at a much lower amount here. And then just reemphasizing, this is just based off sales. You know, actual patient use could be different, and who know, we aren't entirely sure at the moment what dosages people are taking per day or per week. Next slide here. So this next slide, in order to try and glean some amount of information out of the sales data, we took the THC to CBD ratio of kind of our library of products and just kind of made a few quick charts. These are just broken down into products that have no CBD whatsoever, products that have concentrations of 20 parts or more THC to 1 part CBD, and then products that have 10 parts THC to 1 part THC, and then all the way down to products that have more CBD than THC. The reason we use this is because this measure for now is because it kind of allows some level of parity between products. So products like cartridges, for instance, have much higher concentrations of THC. Sorry, the mean THC percentage for a cartridge is 72.5%. And then you compare that to, say, a flower or a gummy, which on average have less than 1% THC for an individual product, just because it's not as concentrated. It kind of gets a bit difficult to compare these products directly. So in order to provide some parity, we just took the CBD THC ratio, or THC to CBD ratio, sorry. We also have a bit more research on THC to CBD ratios in the medical field, showing that having parity or more CBD tends to be good for a lot of uses. So that's another reason to use this. I will add that having no CBD doesn't necessarily mean high THC in this.
I'm just going to interrupt for just 1 second.
Okay.
So I'm just going to interrupt for 1 second on this slide before you move on. It was this sort of initial finding that sort of raised concern amongst at least this board, in that most of our work and research and looking at publications, as well as meta-analyses of therapeutic benefit and ratios of benefit to harm in terms of using cannabis products for medicinal purposes, that both international and nationally recognized consensus guidelines and our findings to reinforce that were that at least a 1-to-1 ratio of CBD to THC, or in this slide, THC to CBD, would be recommended, but at least 5, 10 to 20-to-1 CBD to THC was recommended in terms of optimizing potential therapeutic value and minimizing risks, not only in terms of excessive THC dosing with regards to psychotropic effects, intractable vomiting, those sorts of conditions, but also in terms of abuse liability and being able to maximize the benefits without and potentially reducing and eliminating risk of abuse liability in high CBD to very low THC doses. What we've discovered, and I know I'm going on and on because I really want to underline and underscore this, especially as we start looking at toxicology and issues around that, that we are completely, I'm trying to think of a non-vulgar way of saying it, backwards, bass-ackwards is, I guess, the colloquialism in terms of these ratios and proportions. And so as we start doing this, more and more investigation and looking at what pharmacies are actually selling, and we don't know exactly what people are using, but I think it's not far off to believe that if these are the materials that are being sold, and very high dose THC with almost no or very little, if ever, CBD in combination, no less other non-psychotropic cannabinoids that may have potential therapeutic value in this entourage effect, that we're really right now not in the right direction, and we need some reconciliation of this. Thank you. I'm sorry, Jess, to interrupt, but I want to underscore that, especially to some of our newer board members who have not been part of the conversation, but what has generated some of the concern and what's driving our interest in this product. Thanks.
All right, thanks, Perry. And then we can just jump to the next slide here, Sarah. And then this is a quick breakdown of basically the same chart as the one we previously saw, just kind of broken down into category. This is categorized based mostly on that first sales chart because cartridges, flowers, and gummies were the most popular. I broke those out, then tinctures being a far fourth, and then grouped everything else into an other category. As you can see, a quarter, I'll also add, so the percentages at the top of these charts are the percent of the total. So they should all add up to 100%. So 25% of all products sold are cartridges with THC to CBD ratios of greater than 20:1. I'll also add there, like I mentioned earlier with some of the data limitations, there is an issue of decarboxylation with flowers. On average, flowers have, let me pull up the number, 0.73% THC and 19.95% THCA. These tests are quite are done before decarboxylation, so the flower chart represents pre-decarboxylation, so a lot of that THCA could be is converted to THC prior to use. And then let's just hop to the next one really quick.
Hey, Jesse, sorry, I'm interrupting also. If you go back to that other slide, I'm stuck on that because I'm trying to figure out how we get from knowing that flowers tend to have, less than 1% THC to that chart that says there's no CBD. That's 21%.
I should add, it doesn't necessarily, so no CBD in this chart doesn't necessarily mean high THC. It just means there's a lack of CBD. So like I said, the average THC amount for a flower was 0.73%. The mean specifically CBD percent for a flower is 0.06%. Like I said, there's some complications when you include decarboxylation in that CBDA and THCA in this natural form of the product can be converted into CBD and THC. So I also included on the next slide the THCA mean THCA percentage, and also the mean. I'll throw on the mean CBDA percentage as well before this is uploaded, but the mean CBDA percentage is 0.26%. So there is some conversion. I think the main reason a lot of it doesn't have CBD is at all. A lot of that might kind of move over from the no CBD to the 20:1 after decarboxylation. But the amount converted can range. I think I've heard estimates that like 80% of the acid base is converted to THC, and decarboxylation, but don't quote me on that.
So is it safe to say that about a third of the products in this are in this no CBD category?
Mhm.
And in terms of ratio of THC to CBD, is there any, can you give us any range of what we're looking at? Because that's the bulk of the flowers that are sold.
Yeah, I did an estimate under the assumption that 80% of THCA is, turns into THC prior to use. Again, that's a heavy assumption. But in that case, most of the amounts with no CBD do end up in the 20-to-1 category, and some amounts from the other categories also move to 20-to-1. And then
Thank you.
I have a couple more notes on the version that'll be updated or uploaded after this meeting, but I also just wanted to add that these sales figures are from the start of the program. So from March of 2020 to May 24th, 2022. Any other questions before we move on? Okay. Perry or Sarah?
Yeah. So thank you, Jess. We're going to continue on at least I believe that our work plan will, and we'll talk about that again in a little later on in the meeting. We'll continue to have Sarah Ponce and Jess Hockley continue to update us on this. I think where we're trying to go, just to give you maybe some insight into my thinking and to whatever degree of influence I may have going forward. I think what we're trying to get to is a point where, hopefully over the course of time, we'll have a better understanding of how people are using these products and what the consequences, the outcomes of their use are in terms of certainly, hopefully, a very high benefit to potential harm ratio, meaning a high therapeutic index. That's what we're hoping. But from a standpoint of understanding normative medical medicine, since this is a medical program, how this converts into milligram dosing of one or more combinations of cannabinoids, or what the expected dose per use would be, so that we can actually start thinking about this and relating what's happening in our program, in our state, and people who are using these products with research outcomes in terms of pharmacokinetic, pharmacodynamic, so PK/PD kinds of studies. And the only way you can get there is by understanding what a person's actually absorbing from a pharmaceutical standpoint. And we're a long way off from that, but as you can see, we're sort of moving towards that, because percentages don't really help. What's, any given individual at any given time, if they're using a medicine, whether it's for hypertension or for diabetes or whatever, what have you, there's going to be a dose response of one sort or another, and it may be predictable, it may not be predictable, but we at least have to have some understanding of that. And until we get to that point, we're really sort of flying blind. I'm sort of curious now, just for the few minutes of discussion amongst board members, since we do have people practicing medicine, we have people who are qualified providers amongst us. I want your thoughts and help in moving forward. Are we moving in the right direction with this? Do you have any thoughts, suggestions for Sarah, for Jess, as well as for Rich, as this program and this project moves forward? What kind of feedback might you have?
I have a quick comment, Perry.
Please.
First of all, I want to thank Jesse for putting that together. That was excellent. And I think it does sort of illustrate and show what we need to be looking at and where we need to focus our attention. So I thank you for that. And I wonder about the future as we continue to collect more data, how much data or how much should we be looking at other compounds like CBG and CBN? I know these are very popular at the pharmacies, and with consumers, with patients. They're really enamored by these compounds and their actions, like anti-inflammatory or sedation or other things. But I'm wondering, in future, can you add some of those? Would it be easy to see what the percentages of CBG and CBN and some of these other compounds are?
We do have some of those profiles that we could add. The only issue is that we don't really have a lot of evidence base to back that up for medical use yet. And so that's kind of why we were focused more on the THC CBD ratios.
Yeah,
That's an interesting point, though, because that's the first that I've heard that those products are becoming popular.
And that's my point, is they're popular and they're using them. The fact that we don't have evidence is kind of on our side.
Yeah, exactly.
But Jesse, that is something we could pull. We know those are not as common, obviously. The majority of products don't have those, but we could get a pulse on how many report that they have that in the cannabinoid profile, Jesse.
Yeah, I can actually just include a chart that has the average for each category in the version that we upload. But yeah, of course, the percentages of other cannabinoids are much lower than CBD and THC.
Yeah, it'd be helpful to just know how many have a trace of CBG or CBN of all the products. What percentage have a trace of it, and then of those that have a trace, what's the trend, right?
Dr. Norris? You're not broad, Jennifer.
You're muted.
Jennifer, I wonder if your internet link is unstable. We're not able to hear you.
Sometimes if we turn off our video, the link gets better, right? Hopefully she'll come join us.
I'll just chime in while we're waiting. As a physician in the trenches, I just think that really underscores the importance of our role in education of primary care physicians and advanced practice clinicians on what research is out there for the use of CBD and or THC in the treatment of our medical conditions that we see each and every day. The education piece is so important at this point.
Yeah, I agree, Brian. And I want to emphasize again what Matt said. On our side, we kind of may discount CBG and CBN because of what Sarah's reminding us. There's no, foundation for that in the medical literature. But I'd be curious not just to know what we're looking at now, but kind of trends over time, because, if they're popular products, I would expect that the availability and the numbers would increase. So I think maybe we could watch that as a kind of a separate side.
That's a good idea.
Thanks. Jennifer, you want to try again? No, it's not working. Just to let everybody know, we're a little bit taken off of our trajectory of what we were going to start assigning towards the priorities of research going forward with Dr. Heath's role. We sort of went in the direction of acute pain because there was this piece of legislation that came through, and we'll be talking about that. But on the back burner, just to let you know, and I want to make sure that it's still there. We were going to hope that Dr. Heath would be able to start looking at and be able to report back to this group an evaluation of the literature, looking at what is known, or to whatever extent it is known, about PKPD studies or preclinical, and if there are any clinical trials, and I know there are very few, looking specifically at CBN, cannabivirans, which is CBV, and cannabigerol, CBG. There's not much on others that are sort of natural products where this amalgam of cannabinoids are present in a lot of our products. They are being measured in toxicology through the Department of Agriculture, and so we do. The program is actually involved in measuring them, so we'll be able to report that out. But I think for the point that Dr. Zender brought up from an educational standpoint, I think we need on our website a section that specifically looks at and can inform recommenders. What do we really know about? What do we really know about? Not anecdotal, not self-report, but what does the literature, because that's our role, what is the evidence in terms of any pharmacological activity of these cannabinoids? And to what extent are they potentially therapeutic? To what extent are they potentially toxic? In what doses, etc. Dr. Moss.
I just wanted to clarify on the amount of THC in the flower. I'm getting myself up to speed on Utah. I'm used to labeling being, they're not differentiating, it's just THC, CBD when flower is labeled, and not necessarily THC plus THC acid. And so as a patient seeing actually 20% THC on that flower label, not 0.76 THC, and that they're selling it as the total THC content, and therefore they're not seeing 0.7 versus 0.05% or whatever else. They're seeing total THC and CBD content on a label.
Generally, yeah.
Maybe that would be the way to look at it rather than active THC present, because if it's 0.7 versus 0.06 doesn't seem to make too much sense, rather than looking at what is the total amount there. I realize we have no idea what actually happens when someone smokes it, even if they're not supposed to do that, or otherwise of how it occurs, of what's being, how it's being sold, or what patients might be interpreting as the THC to CBD ratio that they're getting, even if the active form that's present in the flower before pyrolysis is totally different.
That is something we identified. We're hoping also to collect manufacturing recommendations on dosaging for the products. Hopefully maybe being able to gather that data in our database and perhaps put it on the label as well, rather than just the total THC the product. We realized that was a limitation for us as well, not understanding the actual dose that the patient is getting.
Right, and from a very pragmatic standpoint, Dr. Moss, I think if a thoughtful clinician is recommending that a patient start with, let's say, on a per dose basis, 2.5 milligrams of THC, 5 to 10 milligrams of CBD per dose by whatever route of administration. How do they translate that recommendation, for which there may be some evidence of at least potential benefit and minimal harm, minimal adverse effects, to whatever that product is in terms of total percentages of THC, CBD, et cetera? I mean, it seems like it's a long run between one and the other, and a very difficult process for a recommender, clinician, to try and figure that out. No less a patient, if the patient wants to really adhere to a best evidence approach too. So I think there's a lot of work to be done. We're getting there. I'm gratified that at least we started on the long journey, but these are all the right questions, and just let's stay on it and keep pushing forward. And I know, Jess, it's difficult with the database you have, but you can tell how important this is by the level of interest in the group. And I think, again, from an access standpoint, my understanding of why a lot of clinicians are reluctant to recommend or to be even involved is they feel like they have no idea what their patients are ultimately getting, or then how to advise them and how that fits in with whatever other therapeutic regimen they're prescribing, and to work, hand in hand with the patient towards their best, health-related outcomes. it creates a great deal of insecurity, I think, on both sides. So the more we can inform and, as you said, Brian, educate, all the better. All right, well, let's push forward. Just wanted to make a couple of comments about the presentation 2 months ago by Carrie Wilcox. I'm sorry, Carrie Silcox, who is the head of highway safety for the state and the Utah's public safety department. And it was a very illuminating presentation. I think, a great concern about the frequency and the increased prevalence of automobile and vehicular related morbidity and mortality in the state over the last 2 years. And is there any relationship between that and impairment in either alcohol and drug related, and a combination of alcohol, drugs, and if they're drug related, which drugs, and if cannabis, as it turns out to be, very high on the list of those drugs that are found in these especially traffic fatalities or vehicular fatalities. Which of that, what is that is been recommended for medicinal use? What's of it is other? And we just, turns out we don't really know as of yet, but at least now we're looking. I think that presentation 2 months ago signaled the first time we sort of really opened up the line of questioning about what is the relationship and how do we understand this. And the outcome of all of that, very gratifyingly, was a great willingness and interest on behalf of the Department of or Division of Highway Safety to become involved in our activities and our efforts to inform and understand. And with that, Dr. Moss has been invited to join in the committee that is investigating all of this. And so, Mike, if you would, I'd like you to at least comment a bit about where that is so far and what your efforts might lead to.
Oh yeah, so far it's just, hey, we're having a meeting. Would you like to join? I'll send you the calendar invite. So I haven't even had a first meeting with them. I was present for that meeting when they gave their presentation before I was officially on the board to hear about it. I can at least speak a little bit from my toxicology background and I think it's part of the adverse effects cannabis, CME that I put together too. We know that cannabis impairs driving ability to some extent for some duration of time, depending on the person and the measure and the dose and all of those other pieces. So hopefully I can take a look at that and see what sort of information they have, and do we know anything about concentrations of THC in these drivers, or is this simply someone who used THC a week ago and then was driving? And are we seeing a big problem with patients thinking that because it's recommended to them for medical use that they are allowed to and safe to drive, which we know that whatever the medication, an opioid or a benzodiazepine, even if medically prescribed, could still impair someone's psychomotor function substantially. So I think it should be good to take a look, at least provide some medical perspective to them. I don't know exactly what that committee or group is. I know I've been invited to attend, but their first meeting I think isn't for another month or so, or they meet every 2 months or quarterly or something like that. So hopefully I can be a liaison between the two groups of seeing what is happening and offer my perspective on interpreting driving studies with the data that they have, and how can we use either blood or urine testing to determine impairment or intoxication in these cases too.
Great. And this presents a great opportunity again for give and take back and forth and communication amongst folks within the state who are obviously have a great concern about public safety. And Mike, we really look forward to hearing more over the course of the next year about what your involvement is. And I think certainly from the discussions I've had with state troopers and local police, they're perplexed by this. They've got a obviously field sobriety testing and they can do alcohol levels and so forth, with cannabis, it's much more complicated. We also know, and through Carrie's report, that there are a lot of psychotropic drugs that are out there that people are using, including antidepressants and other drugs that have profound drug-drug interactions. And most of the involvement, from my understanding of reading the detail of her report that was supplemented, if you, I think, and hope you all received this later, a few weeks later, that was the University of Utah report. There's an ongoing study going on at the University of Utah to try and understand this, that most of the accidents, injuries, and deaths do involve polypharmacy. And cannabis is very high up in the, it's almost, so it seems to be highly prevalent, but there's a lot of other stuff too. And so we just need to understand this better and be able to advise everybody involved. There are a lot of stakeholders in all this about how to protect individual and public health along the way. All righty, any other thoughts, comments about that from the board? Okay, the chronic cancer pain guidance, that was out there. Misty Smith, Dr. Smith was very helpful in providing very useful feedback. Based upon that feedback, we did a revision and included some data and summary conclusions as a result of that went back to Sarah Pons. Sarah, I think, am I correct in that has now gone out for review by the board to be able to act upon that today, or am I?
No, so Lauren submitted her response and review, and I was waiting for your feedback on that. And then we could, whether or not we wanted to include those recommendations, and then we could send it out to the board. I don't know if you saw that email from Lauren.
Let me just see if I understand from the board standpoint, have you all had ample time to review that? And excuse me, allergies are driving me crazy here.
I have not sent out Lauren's recommendations.
Have you all had an opportunity? Would anybody like to spend more time on it? Or I just want to sort of a sense of the board now. Are we ready to move towards approval, or do we want to give you more time to review?
Sarah, this is the email that I responded to with the, is that right? Are we talking about that same email and that same document? Or am I off track there?
No, what from Lauren just went to Perry and myself.
Okay.
Recommendations.
Okay. So we've not received. I
That's
think
correct. I have not sent those out to the board.
Okay.
Okay, so we really need more time. So what we'll plan on doing then is I think we do now have a version that's responded to the input for edits that now have been done. So we'll send that out to the board for review. If there are any other comments, we'll make them. Otherwise, we'll put that on the agenda for July's meeting to have any further discussion and then to move toward approval of that. And then we can at least get that document into the portal for general consumption, if you will. Sound like an acceptable plan? Okay. Now, one of the more really greatly appreciated piece of work that Dr. Heath sort of has kicked off her sort of maiden voyage in her new role with is a deep dive into the evidence base for the potential of cannabis use for acute pain, which is now a qualifying condition. And so I think that has now been sent out to everyone for review. And Lauren, I would appreciate it if you could just sort of give the headlines in terms of your process, but also then the resultant conclusions you come to, because ultimately what we'll want to do is have some additional time, probably for some thought after this meeting, and then to bring that forward to the board again to approve, so that can enter into our portal of useful information for both professional and public availability. So Lauren, why don't you take it from there?
Sure, thank you, Dr. Fine. So I did prepare some slides that summarize the document that was sent out to the board. I can go through those now. Let me just share my, oh, I can't share my screen apparently.
Sarah, do you have a copy of that presentation of Lauren's?
Yep, if you want me to share, I can, Dr. Keith.
Sure, thank you.
Great.
All right, this is going to be a lot of information. It's outlining the document that was sent out to the board. I'll try to get through it quickly. But again, I was just performing a rapid literature search about cannabis or cannabinoid products for acute pain, and I have no conflicts of interest to disclose. Next slide, please. So I'm going to briefly cover the methods I used just so you have an understanding of what type of evidence that I was looking for. And then I'm going to summarize my findings from systematic reviews and randomized control trials. Next slide, please. The objective of this review was, in light of acute pain being a new qualifying condition, to look for and summarize evidence to assist with decision-making by the CRRB. The evidence that I looked for is summarized here. So included studies were systematic reviews, abbreviated SRs, of randomized control trials or randomized control trials themselves. Included interventions had to be a cannabis-derived product, or a cannabinoid of any type, and I use CBPs to refer to these. Trial participants had to be people with some sort of acute pain condition. Acute pain was considered pain, the duration no longer than about 1 month, resulting from tissue damage. Note that for feasibility and due to the availability of trials of people with an acute pain condition, I did not include laboratory-based human volunteer trials in my search. Next slide, please. So I searched 2 major bibliographic databases, and for the RCT search, I based it off the date of a high-quality systematic review that I found. For feasibility, I focused on extracting information about pain intensity outcomes and the risk of bias or quality assessment of randomized control trials based on what was reported in systematic reviews that I found. If it wasn't addressed by a systematic review, then I did my own risk of bias assessment using the Cochrane risk of bias tool. This tool addresses common bias considerations for randomized control trials, methodology, such as related to randomization, blinding, attrition, and selective reporting of outcomes. Thank you. So just in brief background, which I did not go into a deep dive on, in general, preclinical studies support the potential effectiveness of CBPs for treating acute pain. As I mentioned, human experimental models have also examined the potential efficacy of CBPs for acute pain. Based on evidence from expert opinion or reviews addressing these laboratory-based studies, the trials primarily using THC have demonstrated mixed evidence of analgesic efficacy. An expert summarized these efficacy outcomes from 7 experimental model studies, saying they are mostly negative, and in 4 of them, more intense pain was reported at high doses. I also saw 2 laboratory-based trials that failed to demonstrate a benefit for oral CBD for pain intensity, allodynia, or attenuation of hyperalgesia. Next slide, please. So I identified 11 relevant systematic reviews and 11 RCTs published between 1981 and 2022. The CRRB should note that 4 of these studies lack information about approval by an institutional review board or similar ethical committee, and none of the systematic reviews included all 11 RCTs. The research question of the included SRs is or was variable, as shown at the bottom of this slide. 4 of the systematic reviews specifically focused on CBPs for acute pain or post-surgical pain. Next slide, please. Of the systematic reviews providing a conclusion about the body of acute pain evidence, the majority concluded that CBPs are not better than control for analgesia. 2 SRs did find a possible benefit of CBPs for acute pain. One of these systematic reviews described the positive results of a single trial of levonantridil for postoperative pain. The other performed a meta-analysis of 6 acute pain trials, which found a small but statistically significant benefit for reduction in patient-reported pain scores that favored CBPs over control, which is shown at the bottom of the slide. However, there was evidence of statistical heterogeneity, and the authors concluded that one possible contributor to the heterogeneity is route of administration. That is, observed analgesia versus control might be present with intramuscular levonantridil, but not oral CBPs. These authors also graded the overall body of acute pain evidence based on their 6 trials of 678 participants as being low quality due to a serious risk of bias and serious inconsistency for the reported outcomes and adverse effects. Next slide, please. A meta-analysis from another SR including postoperative pain trials found increased pain at rest 12 hours after surgery, but not at earlier time periods for the CBP arm relative to placebo. This meta-analysis also had evidence of high heterogeneity. A few SRs looked at the outcome of changes in opioid use based on morphine equivalents consumed when used concurrently with a CBP. This limited evidence does not support a reduction in opioid use when used concurrently with CBPs. An acute pain-focused SR did not find significantly increased odds of serious adverse events for patients receiving a CBP compared to control, but they did find significantly higher odds of dizziness and hypotension for CBPs versus control based on their meta-analysis of 6 trials. Next slide, please. Now I will summarize study characteristics and efficacy outcomes for pain from the 11 identified randomized control trials. All of the trials were randomized, controlled, and double-blinded except for one trial with unknown details about blinding. The total number of participants ranged between 20 to 340. Based on the risk of bias reviewed by the SRs, all trials except for 2 were rated as having an unclear risk of bias for at least 2 domains. Most trials compared the CBP to placebo, and in the majority of them, 7 out of 11, reported allowing use of other analgesics for all study participants. An active comparator was also used in 4 trials. The acute pain study population was primarily post-operative patients after various types of major surgeries. One of the post-operative studies of total knee arthroplasty included patients with chronic pain at baseline. Other populations include dental pain after tooth extractions and one trial of patients presenting to the emergency room with acute non-traumatic lower back pain. Next slide, please. The CBP intervention used among the 11 trials was heterogeneous in terms of the type of CBP, the dose used, the frequency and duration of use, the route of administration, and timing of the administration relative to surgery and post-operative pain trials. This table summarizes the studied CBP. Note that the CBP was a single cannabinoid in all 11 trials. These were THC congeners in 7 trials, including a non-FDA approved intramuscular levonantridil in 3 trials, and CBD was used in 2 trials, once as a single dose, and the other time it was applied topically as a stick to the knee after arthroplasty. The 2 dental pain trials studied experimental cannabinoids, one of which is a type 2 cannabinoid receptor agonist, and the other is apparently peripherally selective type 1 and type 2 cannabinoid receptor agonist. All trials except for 3 administered only a single dose of the cannabinoid, and the longest duration of cannabinoid use was topical CBD 3 times daily for 14 days. Next slide, please. Regarding analgesic efficacy in these trials, the majority of the trials reported some measure of patient-reported pain compared to placebo and found that the studied CBP was no better than placebo. However, 2 trials did show some degree of analgesic efficacy. Both of these studies were of the intramuscular levonantridil for post-operative pain. One found a significantly decreased pain relative to placebo, and the other reported decreases in pain with higher doses of levonantridil versus placebo, of unknown statistical significance. Both of these studies were rated by SRs as having an unclear risk of bias for all Cochrane bias measures. The statistical significance of the third levonantridil study versus placebo is unknown, but the active comparator meperidine outperformed levonantridil and placebo. One trial of oral nabilone for postoperative pain, where pain was not the primary outcome in the study, found paradoxically increased pain at rest for the 9 to 16 hours postoperative period for participants receiving the highest dose of nabilone studied, 2 milligrams, compared to participants receiving placebo or the lower dose of nabilone. The dental pain trials of experimental cannabinoids included an NSAID comparator arm that showed a significant benefit for the NSAID compared to placebo, but that was not observed for the cannabinoids versus placebo. Next slide, please. So in summary, the review included 11 randomized controlled trials of between 20 to 340 participants that used a CBP versus a comparator. And most of these studies, that is 8 of the 11, were conducted in the acute postoperative period with a short length of follow-up. There is uncertainty about the risk of bias for 2 or more assessed bias domains for the majority of included trials. The CBP studied was a single cannabinoid in all trials, and most of the studies administered only 1 dose and at variable times relative to surgery. Therefore, there is a lack of information about the potential efficacy of repeated doses of cannabinoids and for combinations of cannabinoids or other types of cannabis products for acute pain. Overall, definitive conclusions about the body of evidence of CBPs for acute pain are hampered by the significant clinical and methodological heterogeneity among the available trials. But the limited evidence from the individual trials to date is inconclusive about the analgesic efficacy of CBPs for acute pain. So that was my summary of the document that was sent out to the board. Thank you for listening, and if the board has any questions about the summary, I'm happy to address them.
Any questions for Lauren? Other than a little round of applause. As a really
Yeah, thank you, Lauren. That was really comprehensive and informative.
I'm gonna warn you, Lauren. I'm gonna actually recommend that this be a lecture that you've done all this work. Provide for. Oftentimes there. Maybe a few times a year, there's a combined surgery anesthesiology grand rounds. I think this would be a very important topic for that. Brian, I think you had a question? No? Sorry, I thought I saw a hand.
I was just going to clarify, Lauren, were any of the routes of administration inhaled for any of those trials?
No,
was this all IM or oral or topical? Yeah,
it was IM and 3, topical and the rest of the others, or sorry, oral and the rest of the others, and topical for CBD in 1 trial.
Just by, go ahead. I'm sorry, somebody. By way of background, go ahead, Misty, please.
Oh, the only other thing that, excellent summary, fantastic job doing that. When I looked at the data in preparation for today's meeting, particularly at the levonantridil studies that had some moderate efficacy, when you looked at their actual data, there wasn't dose dependency observed, which is also a matter of concern. Even when there was positive results, it was not dose dependent in any way.
Can you just elaborate for the non-researchers among us, why is that concerning?
So typically in a dose response study, you would anticipate as the dose increases that you would see an increase in the biomarker that you're considering. And typically in a safety versus efficacy study, which a lot of these were, you would expect as you increase dose to potentially have greater efficacy, but a greater risk for toxicity. And they did oftentimes see an increase in whatever adverse effects they were actually measuring as they increased at dose. but they didn't necessarily see an increase in the efficacy, which means they were either plateauing or in some cases getting an inverted type response. But even that wasn't clear. There was just no clear pattern, which leads you to wonder what all mechanisms are actually contributing to the effects beyond the cannabinoid or the endocannabinoid system.
Thanks, Misty. Dr. Norris.
I do have a question. Hopefully you can hear me now. I'm just on a cell. Can these lectures or videos be uploaded to the website so that they can be accessible for QMPs to listen to? That kind of a lecture would be really helpful, I think, for physicians who are out here in the world recommending this for patients and being able to respond to questions.
So all of these meetings are uploaded to our YouTube site, which is available via link on our website. Also, the slides have been uploaded to the same website, and all the presentations we have are available there during the meetings.
Is there any? Is there a message sent out?
Could everybody hear? Could everybody hear Sarah? Could everybody hear Sarah? It's a little hard to hear Sarah Ponce. What she said was, all these meetings are recorded. They're available and accessible to the public. Once this goes out and it's approved by the board, this will be this presentation will be also on and the conclusions will be on the portal.
And I think Dr. Norris was getting at, how do we draw attention to it, right? And we send out a monthly update to the stakeholders, which includes providers. And we can put a little blurb about it there. And also, with your permission, Dr. Heath, we could think about splicing the audio so it only shows your presentation. And that way people don't have to fast forward through. And then sending that out and maybe creating using your PowerPoint and then creating something that even summarizes things a little bit more and that links to your PowerPoint, right? And then we have the ability to reach out to all QMPs in the program, sending out that email, and also to the UMA. We could share it with them and they could choose to use it how they want. UMA reaches out to us, and in other medical provider associations reach out to us sometimes for content. And with your permission, Lauren, we could identify an easy way to highlight some of the basics of that presentation. That's a good idea, Dr. Norris. I like that.
Rich, most certainly, I think that's a great idea, that every time this board comes out with a new conclusory recommendation based upon, for instance, we'll have cancer pain and then we'll have acute pain coming out next month, presumably, that if a blast email to all LMPs and QMPs can go out with that anytime there's a new thing, as well as to obviously the legislators, the Health and Human Services Committee. They need to know.
Right.
They've asked for directly to them and bypassing their staffers, because apparently things have not filtered up from staffers. So, and I know, Rich, you're meeting with them and have invited them to all our meetings, but they're busy and have other things going on. So if we can proactively, the nudge can be they get it automatically. That would be just super.
Yeah, Rich,
Right.
how do you get it on their YouTube feed? That's how we really need to get it.
Yeah. Also, we
can ask the legislators what, so the normal route would be going through their aides, but as Perry's pointed out, that's not working. We can ask them, we have enough of a relationship to ask them, where can we put these that are easily accessed by you?
Sure. I'll have that conversation with them. I meet with them in person here within the next few weeks. And actually this week, I'll be meeting with some of them on Thursday. So, yeah,
And
I think that's a good idea.
That would be great, Rich, if you
Sure.
did that. And not to create more work for all of us, but I do think there are some presentations that we've experienced, the board has experienced, is that, you know, if we went through recorded meetings, we'd see them, like Adam Gordon's presentation
Yep.
on cannabis products for opioid use disorder
Mhm.
was excellent, concise, and should be out there. That's a hot kind of topic that comes up every year and that a lot
Right.
of patients are interested in as well.
And Katie, just and for everyone, just so you know, just this week we hired an outreach specialist whose one of their duties is to communicate the information like this to stakeholders. And so we'll be, and she's actually part of this meeting today. So we'll be able to meet with her and define exactly what messages we want to send out and define the group that we want to send it to. And she'll also help us develop some of those ongoing notices to those critical groups of providers and stakeholders to make sure that they're aware of some of the important topics that are coming up and in the conclusions and things we're learning and things we don't know that come up during this meeting. So I'm going to put together an actionable plan that we can execute on and report back to you about how we're doing on sharing these messages. That's a good idea.
Dr. Norris, I see your hand is up. Is that ongoing? And Misty, I saw that your hand was up. Did you have a follow-up?
More of a comment than anything. I just feel almost obligated as the researcher in the audience, as a Cannabis Research Review Board member, that really, as a board, I think it's important that when we convey this to legislatures or other powers that be, that there really is an unmet need for additional research, clinical research in particular, focusing not only on the various routes that we're seeing consumers utilizing the products, as was mentioned, the inhaled route, topical routes, et cetera, beyond oral administration, but also sex-dependent differences in the responses. That's really an unmet area in the research, both preclinical and clinical. And there's a need for those topics to be addressed so that we can give more beneficial reviews.
Yep.
Moving forward.
Agreed. That's an important message to send for sure.
Yeah, Misty. And with that in mind, Rich, maybe we've got a moment here. Where are we with the $500,000 that was appropriated for outcomes evaluation and RFA that was going to go through the health department? Where's that stand at the moment?
Yeah. Sarah Ponce, I know, is she's got the pulse on where that's at. Sarah, do you mind giving us an update on that?
Yeah, I hope you can hear me. Okay, that is currently with the Division of Purchasing, waiting approval. And once that gets final approval, we'll be able to release the RFP for academic researchers to apply. And that's where we currently are with that.
Can you give a sense of timeline? What typically, when might that go out, in the fall or when?
We're hoping probably by the end of summer, I think would be the best estimate at this time. The Division of Purchasing has to go through all of the funding requests from this last legislative session, and there's several. So unfortunately, it may take a while. So we're hopefully by the end of the summer, we'll be able to post the RFP.
Okay. Just for the sake of keeping that alive in our minds, since it's critically important, as Misty brought out as well, let's just make that as a permanent, if you will, if you're all agreed, an agenda item. Just to update us where that's at, so we don't lose track of that critically important at this point. Okay. Well, good. Seeing no further hands, let's move on. We have a sort of a housekeeping piece of business, and that is nomination of officers or leadership of this committee or board, rather, going forward from July 1 on. And may I hear a nomination, Dr. Zender?
Yes, for the board chair, I would like to nominate Katie Carlson.
And for vice chair?
I would like to also nominate Matthew McKiff.
Is there a second on those nominations? Dr. Carlson as chair, Dr. McGiff as vice chair. May I hear a second? Second from Dr. Norris. Okay. Are there any other nominations? Okay. Hearing none, we will take a hand vote. Everybody know how to use their little reaction button. Either put up your hand or put it up virtually. So all in favor of Dr. Carlson taking on the responsibilities of the board chair for the next year, as well as Dr. McGiff for vice chair, please signal with your hand raised. And I see that that is unanimous. So be it. Congratulations, and thank you very much, Dr. Carlson and Dr. McGiff, for accepting these nominations in your new positions. We'll look forward to your new leadership come July 1. And just so everybody knows, I believe that going forward, I have one more year on the board and will be serving then in the capacity of the immediate past chair and supporting Drs. Carlson and McGiff to the extent that they wish and that I can. And obviously I'm very much engaged in this. Dr. Zender has another year as well. And we'll continue to appreciate and value his input, and then all other board members going forward. Again, great appreciation for all of your efforts. And with that, I want to turn the podium, if you will, over to Dr. Carlson to briefly discuss the work plan going forward for the next year. And then I'd like to maybe invite some comments from Rich Oborn as Executive Director of the Center to talk about his view of the year coming forward, what might be in development in combination with his board, as well as maybe some highlights of the meeting that he just attended that brought together this brand new group of excuse me, of leadership of similar pardon me, of similar organizations throughout the states. So Dr. Carlson.
Thank you, Perry. And thank you, Drs. Norris, Zender, McGiff, Smith, and I left one out, Moss. Welcome and thank you for the nomination. It's been a really great experience for me so far working with all of you, and I look forward to this year. And thank you to the Department of Health members, Rich and Sarah and Lauren. I really appreciate the structure and the service that you provide. Sarah Lalos, do you have I just want to show 2 slides while I go over, it's probably 5 minutes of just what, with the help of Matt and Perry, what I've put together in terms of a strategy for this next year. Do you have those slides, Sarah?
Oh, I'm sorry, I do not.
Okay, I just thought of that. I could try, I don't know, Perry, if you want to send them, I can do it without the slides. I don't think I can share my screen, but I'm going to try.
You have to be invited as a host to share.
Oh, okay, so I cannot share them as a non-host. So I'm going to just go through them. And let's see. So, and now I just signed myself out for some strange reason. So essentially what we thought might be helpful would be to just summarize some of the common components of what makes a medical program, what makes a program medical. And what we came up with were 3 essential components: a body of knowledge, and set of ethical standards that would serve as the backbone and the principles for the practice of that medical program. The second would be an educational system that's easily accessed by practitioners. That's an essential component. I think Jennifer's comments today touched on that in regards to Lauren's lecture. And the third component that's essential is a system for continuous quality improvement and research. And I think that third component is what this board has been working on since its inception years ago. And we now have a really great team embedded in the Department of Health to help us with that, that third component. So those 3 components: body of knowledge, an educational system for practitioners, and a system of ongoing quality improvement. We feel we really need to abide by in order to create this medical cannabis program for the state of Utah. So on that note comes our strategy for this next year, our working strategy. Under the first component, that body of knowledge and ethics, we, as you all know, we're working on creating an updated and accessible list of available products. And that list will comport with best evidence and consensus-based guidelines for efficacy and safety in using those products. So in summary, that in that first area, we really want to enlist everyone's support and efforts in creating that list. And thank you to Sarah and Jesse for all the work that you've done so far on that. The second component, education, we have our website, and I think we are familiar with that, and people within the Department of Health are familiar with that. It's not really out there on the kind of highway of what practitioners use in terms of getting their CME and making sure they're staying up to date with education. So and I think this area can grow and needs to, and we need everyone's input, but we do have a current access point with the UMA, and we already have an educational module with the UMA. And Perry, I think this is fair to say, unless you've changed your mind, Perry has agreed to work on updating that, the cannabis section of the UMA controlled substance curriculum.
Yeah, I'll just say that I've actually was able to get a jump on that and pretty much complete my review of what's there and what's already outdated and updated, a lot of which I was able to incorporate much of the work we've done in the last year or two. And I have a meeting with, I've sent Michelle McComber, who's the executive director of UMA, who asked me to do this on behalf of this board, both a redlined as well as a clean copy of what I've come up with. It's larger than it was because there's more information. A lot of it is referred to our website, and I've given that information. So when individuals go through that CME program, they at least have access to that. She and I will have a meeting scheduled next week, next Tuesday, a week from today. We will be going over that. I'll update you, Katie, on where that's at. My request to her, and she, I believe, will go through this process, and I'll inform you later, would be to send this as a draft to other clinician groups throughout the state, whether physicians, nurses, podiatrists, family medicine, other large stakeholder clinician groups, healthcare professional groups, advocacy groups, others, so that we basically have some feedback mechanism, and then we'll finalize that through some process through the UMA. They've got their own processes, but most likely also suggest that it go through our board. So it's something that's maybe another 2 or 3 months, and maybe this will be something that'll be updated officially within the fourth quarter of 2022 or first quarter of the next year. But anyway, I think the heavy lifting is done from the standpoint of my time and effort, but that's where things now stand. So thanks, Katie.
Yeah, thank you, Perry, for that work. And that's fantastic. That's going to be very valuable for practitioners who are trying to stay updated. And
can I just ask that a copy of the information be sent to the department, so that we have a copy of that, it's being sent out through the UMA as well?
Yeah, I'm gonna, since this has really been requested through the UMA, when I meet with Michelle, I'm going to make that suggestion and recommendation, but it's really hers, her process now to run. I'm doing this as not in my official capacity as chair of this board, nor in my capacity necessarily as at the university as a sort of nobody else wanted to do it or was willing to do it. So I just simply agreed to do it because it really needed to be done. And I got to share with you as an anecdote. My daughter is a PA at IMC main campus. She's on the orthopedic trauma team. She deals with a lot of individuals with both acute and trauma and chronic problems as a result of that, as well as pain-related issues and so forth. And she just went through the UMA program as part of her requirement for her job. And I got a call out of the blue from her saying, "This doesn't sound like the kind of stuff you talked to me about." And so I went and reviewed it and talked to Michelle and said, "Boy, is this stuff, this really needs to be updated." And she said, "Well, thanks for volunteering," basically. I said, "Well, see if there's anyone else around." And ultimately, this is where it happened. But, it was fortuitous. None of us sort of go around reviewing this stuff on a regular basis. But boy, it's scary when there's either misinformation, disinformation, or antiquated information out there where that practitioners are sort of, it's a one and done. They don't think about it for another several years because they don't have to go through. It's really controlled substance education, and this is module 6 in the controlled substance education process.
Yeah, previously Dr. Woolsey and Dr. Babbitts provided feedback on that. So
absolutely.
Yeah. So we're kind of tying together these components and the work that we've done in terms of reviewing literature and just the experience and knowledge that we've gained. And we need to have ways to feed it back to practitioners. And this UMA module is an essential piece, partly because of what Perry's saying. Right now, it's out there creating liability. So we can correct it and update it. And then I think we all need to think about ways that we can provide accessible educational platforms for practitioners in Utah. And I think that parallels our effort to educate legislators because of the unique limitations on cannabis as a medicine. And so it's a multi-pronged effort, but it's an essential piece of making this program medical. And the final, I can be real brief, just to wrap up, is our effort to do continuous quality improvement and research. So we will continue in that vein, reviewing literature that is methodologically sound. And that's going to serve as the basis for any recommendations that we make. So that's it. I just want to kind of quick summary, we want to update that list of products and make sure that that list comports with our current evidence and guidelines. We want to ensure that practitioners in Utah have access to sound educational materials in order to use cannabis products safely in their practice. And finally, to continue our efforts in expanding our knowledge and understanding of cannabis as medicine and do that in a methodologically sound way. So thank you all. I'm done, so I will turn my microphone off.
We anticipate that you'll never be done. That as long as you've got blood coursing, your thoughts are just wonderful. In fact, I would suggest maybe as long as I've got 12 more days of minimal yet some authority, Katie, that next month for the meeting, that maybe we introduce the meeting with your slides since we weren't able to see them. I think somehow visually it's more impactful when we really see things laid out, and you put the effort into making those slides. It would be helpful, and I think from that standpoint, it would be also useful then to put those, Rich, on the portal so that people can see what it is that the work plan is for the year going forward, and what the sort of the leading pillars. I think what you've established, Katie, are sort of pillars and foundation for what the this Cannabinoid Research Review Board, Cannabis Research Review Board is doing. Our legislative mandate, again, is very broad, and we're sort of, it's evolving and organically shaping in real time. And I look back in reflection of the last 2 years, we've come a long, long way. And, moment by moment, it doesn't seem a lot, but when you start adding it up, there's been a lot more communication, a lot more effort to involve more broad-based and deeper roots to create a legitimate medical program that serves the interests of individuals with medical need, public safety, legislative interests, constituent interests, all those. And with that, that's a segue now in our last 20 minutes into any thoughtful feedback, discussion from those who have joined us today. I know it's always more frustrating on a virtual platform than in person. I think from the standpoint, as I understand it, going forward, we've not made any decisions to move to in-person meetings as of yet. We'll continue on this platform at least for a while, and we'll reevaluate over the course of time. It seems we save a lot of time of individual people volunteering for the roles here by not having to drive to and from the Department of Public Health buildings and get more work done. Although there is something about in person that's beneficial too. So we'll continue to reevaluate. I'm now going to turn over to, as your maiden voyage here, Sarah, to sort of run the show, calling on individuals. And if you have a question for a specific board member, please ask. I see Christine Stenquist has her hand up, but I'm going to turn it over to Sarah to run this part of it and to sort of mind the clock. I'll now go mute as well unless I'm called upon.
Okay, and those people speaking, remember to say your name, your affiliation, if you have any conflict of interest when you start. And Wendy's going to be helping with the time. So you'll have 2 minutes to present, and Wendy will call out if you get to your 2 minutes. So go ahead, Christine.
Thank you. My name is Christine Stenquist. I'm with the nonprofit patient organization Truce. First off, I just wanted to thank Dr. Fine for all of his hard work in this space and on this board. I know that not everybody sees eye to eye, but I know that everybody on this board is trying their darnest to make sure that we have a good program. And I am very appreciative of his efforts in working with us. And wanted to thank and welcome the new members who are coming onto the board. My question and my statement is how can I help facilitate introductions to cannabis researchers and doctors who are in this space that we are familiar with so that it can be of better use to the health department. Dr. Fine, you've been introduced to Ethan Russo, who many of you are aware of his work and research. He is a friend and ally to me in this space and wants to continue his relationship with Utah, however that looks. Dr. Bierman as well is another individual who has quite a bit of expertise that I think would be very beneficial for our state. So if you guys could just guide me on how I can facilitate those introductions for your staff.
Well, my suggestion is to continue to just keep the channels open, mostly filtering, if you will, through Rich or Sarah Ponce to direct sort of traffic accordingly. I think there will be the opportunity in the next year. It will be up to Doctors Carlson and McGiff, but as we go through agenda forming, when we'll maybe have specific topics that we'll want to take a deeper dive. And if they have already sort of in the can lectures, if you will. I know Ethan very well, and is a very thoughtful researcher and a voice in all of this. I think he was very helpful in our Delta 8 conversations. But I think we'll just maintain these channels, and if there are any specific subject matter, we'll consider them sort of subject matter experts, and we'll just go back and forth as we need them. We don't need to reinvent the wheel by any means.
And that was my hope. Sorry, go ahead.
Perfect. Great. So thank you.
That was my hope, not to reinvent the wheel. Thank you so much. I will make those introductions through Rich.
Absolutely. Thank you.
Any other questions?
Okay, maybe as people are thinking, Rich, we do have a few minutes. Maybe you can sort of supplement or complement or whatever Dr. Carlson's thoughts with where you see the program going, where the funding is, where the resources are. I know that there's some indebtedness that was created, and how that, if you will just sort of give us the mechanics of where you see things going forward over the next year as well.
Sure. Yeah, happy to do that, and I can be brief. So the Center for Medical Cannabis is preparing to be a part of a merge with the Department of Human Services. So there's the Department of Health that we've always existed with since the beginning of the program, and that is preparing to merge with the Department of Health and Human Services to create one merged department as the Department of the Utah, as the Utah Department of Health and Human Services. And that merge formally happens on July 1st. So next time we meet, that will have happened. We've already assumed the logo, but legally it will formally be made official on July 1st. So as we move forward into that, we look forward to one, I think, supporting the Cannabis Research Review Board in the ways that I mentioned just earlier. We've just taken on a health program outreach specialist who will be our medical cannabis outreach specialist that will help share some of the critical public health messages that we believe are really important for patients and providers and stakeholders and lawmakers, as we've discussed, to understand and be informed of. And we hope that prompts conversation about these topics, and that conversation is constructive as providers seek to navigate this new alternative type of medicine with their patients. We also, one of our legally mandated assignments is to do a market analysis to determine whether additional licenses are needed in the program. Utah's program is a small market compared to other states. Some states have decided to not put any limits on licensing. Our state has some flexibility. We've started with a very small number of licensees. We acknowledge that. We want to assess the market and see what the demand is for additional locations. And so that report is due by October 2022. So that'll be happening this year. And we'll be engaging with the industry and with patient advocates about that conversation as well, sharing information with them, getting public comment, and we'll notify board members about that project as that moves forward. On that topic of additional licenses, there is a 15th medical cannabis pharmacy location that is opening in Price, Utah. Should be open by the end of this summer. And we are excited about that location, although it won't serve, like an urban location would, the volume of patients, but it is a critically located, geographically located spot where people that would have otherwise had to drive hundreds of miles in order to get to a medical cannabis pharmacy, they'll be able to drive to Price to get that in that south central Utah area. So also on Thursday, there's a medical cannabis governing structures work group meeting that the legislature is convening. This is the first meeting of this work group. And this work group is comprised of Senator Vickers, Senator Escamilla, Representative Perry, I believe Representative Ward, Representative Jennifer Daly Provo. And it's a public meeting, so anybody's welcome to join virtually or in person up at I believe it's in the Senate building. And at that meeting, legislative staff will be presenting on some research that they've done about the medical cannabis governance structures that exist in other states. And there's this decentralized or shared authority that exists in Utah between the Department of Health and the Department of Agriculture. Everybody's familiar with that. And that exists in other states as well. But more common in a medical only state is a centralized authority with a Department of Health or a different department, state agency in charge of the full program of medical cannabis. And sometimes in those centralized models, they have a commission that helps run it, like DABC or something like that. Like in Maryland, they have a medical cannabis commission. And so the legislative staff will be presenting on what these different models look like. They'll be presenting some options to lawmakers that lawmakers can choose to take action on legislatively and require that the medical cannabis oversight within the Department of Health and Human Services centralized with the processor and cultivator and independent testing laboratory oversight that Department of Ag has, and create some streamlined efficiencies between our teams and be under one single centralized agency. And like I said, that could be the existing Department of Health and Human Services, or it could be Department of Agriculture and Food, or it could be something else. But what we see in most states is that it is within the Department of Health or Department of Health and Human Services. So we are going to be presenting at that meeting as well. There'll be some recommendations or factors that we want to make sure that the legislature considers in that. Now, that opportunity could translate into some savings for us. There's reasons why it could also translate into some increases in expenses. So we'll be sharing those thoughts with the public and with lawmakers on Thursday. And we're looking forward to that.
What time is that, Rich?
Let me confirm. I believe it is at 1 o'clock. Just a second here. I've been out of 10.
That out to us, maybe?
Yeah, it's 2 o'clock. Yeah, and I can send you a link.
That would be
Sure.
great. Thanks.
Yeah. And great. So that is a critical study that's happening. And like I said, it's just at this point a study. There's no bill that's been proposed. There's no prior decision that's made. This isn't decided what we're doing. Brandon Forsyth and I at Department of Agriculture, we've had conversations about potentially what could streamline, and we'll share some of those thoughts at the meeting on Thursday. Also, software improvements. We've got some critical improvements that are launching later this month that we've been testing. We've got a team that's just worked tirelessly on testing those, and Sarah Lelos, in fact, has been a part of that team and doing a good job of ensuring that the software is working like it should in implementing some of the legislative changes that have come about. If you're interested in learning more about that, reach out to me. I can share you details about what those look like. But the bottom line is that they are improvements that will help us and help the pharmacies serve patients better. Also, the RFP oversight, that's an important project that Sarah Ponce from our end will be leading as we work on evaluating some information about the industry and about patients and about the data that we collect, and and how chronic pain is impacted by medical cannabis. What are we seeing in the reports from patients as they self-report information? Also, just outreach to stakeholders. That's an important part of what we're doing. And also, let's see. Oh, the integration with the Utah Controlled Substance Database is also a major undertaking. The key there is that cannabis products are so very different than other controlled substances. That's not a surprise. We knew that going in. But in order to track them in the same system and report them, there is a ton of work that has to be done on the back end. But we've started that work, and we're making good progress on that with our friends over at Department of Commerce. And we don't have an exact time frame of implementation of that, but it is something that will be, I think, a valuable resource to not just the providers in the program, but those providers who don't decide not to recommend cannabis, but just are trying to learn more about what their patients are consuming, and they're trying to verify something independently. And they will in the future be able to do that in the controlled substance database. So that is all. If you want more, I'm happy to share or answer questions, but that's the report.
The only question I had, Rich, I mean, maybe for a minute, and I do see there's one more hand up by Dr. Viner that Sarah, we can go in that direction in another minute or two. But Rich, if you were to summarize where you think we stand, sort of state of the art, state of the science, state of the regulatory policy world, as Utah, as sort of the newcomer to this group. A lot of states, maybe 30 plus, have preceded us in this. Where do you see us as the same or different? In what ways are we maybe ahead of the curve? What do we need to learn from others? That's a big question for a minute or two, but just your thoughts.
Yeah, I love that question, because just last week I was meeting up with cannabis regulators across the United States, up in Washington. And I got to learn about what's happening there. And what became quickly learned and admired by other states about Utah is that the Department of Agriculture and Food in Utah has a lab that acts as a reference lab to the private lab that does testing, randomized testing on all the products that are sold in Utah's program. And one concern across the United States has been the accuracy of the tests that are run on the products that are sold in cannabis programs across the United States, adult use and medical only states. There's this collusion, unfortunately, that exists between testing labs across the United States and the dispensaries or manufacturers or cultivators that they're supposed to do testing on products for. And varying degrees of standards that they use. And it's concerning because there's just a lot of concern about the accuracy of those certificates of analysis that are done on the products. So in Utah, we have the advantage of the Department of Agriculture and Food and law policymakers investing in the value of a lab there at Ag that acts as a reference lab to make sure that the testing that's done in Utah is accurate, and that they don't just rely on a licensed testing lab, but they reference or they ensure that those tests are actually accurate. And when they're not, they have a conversation with those licensees about what they're seeing, and they work together and become experts about what they're seeing in the products in Utah. So other states wish they had a lab like that, and they don't. They just trust that the licensed lab is doing it correctly. And so early in our program that was launched, and we are very fortunate to have been able to continue to have that. And I know Ag plans on building that over time and gathering more resources. There's been I think an issue with getting some of the supplies that are needed to do all the testing that is needed to be done on the products, to check for certain things that the current supply of equipment does not allow for. But that issue is scheduled to be addressed later this year. And so they should be able to get some of that additional equipment that's needed to do the full scope of tests. But that I think is a really good example of what distinguishes Utah's program from other programs. I think other programs see the value in the participation of a pharmacist at a location. Other states, most states don't have that. And it's something that I was just chatting with Georgia about their concern about not having that, and hoping that in the future that might be a role that is required. So those are some examples of I think what distinguishes us in a good way from other states. Some things that I see in other states that we don't have in Utah, I would say the public health emphasis is something that we want to expand, that other states have invested a lot of money in. Colorado and some other states have really messaged, send those very concise, clear messages to youth and to providers about cannabis. And there's a lot to be learned about how they've had success in doing that. And we want to incorporate some of those lessons learned in Utah and make sure we're spending our resources in a smart way to ensure that accurate information is consumable by patients and providers and stakeholders about medical cannabis. And the board obviously plays a role in that, doing the research, information like Lauren was sharing today. We feel responsible to ensure that doesn't fall on deaf ears, or that it actually falls, right? We want to make sure there's actually some consumption of that information beyond this group. So I think that's another thing that we want to build that we haven't fully built yet in our program. So yeah, that gives you some examples, Dr. Fine.
Well, thank you very much. I see Dr. Viner does have his hand up, but we've got maybe 30 seconds left for a quick comment from our esteemed colleague in Nevada.
Mark Viner, private practice, psychiatry, no conflict of interest. Regarding the acute pain qualifying condition, has there been any progress with hospitals, pharmacies for continuity of care when one of my patients goes inpatient and say has a procedure, is there for a month for pain, has acute pain? There's all kinds of articles about everything needs to be adjusted, procedures, other meds. And I'm worried as a psychiatrist of them having to stop and have withdrawals and then be given unsafe, stronger prescription meds like insomnia, Ativan instead of whatever they're. So is there, because in Utah, the pharmacy is unique. So can the patient bring in their own, have pharmacy do it like methadone, then pharmacy dispense it on the unit for the patient? Is there any progress like that? Okay, thank you.
Mark, those are great questions. These are all the issues that sort of came up when that legislation went through. I'm just going to say that it's extremely complex. None of those questions have been fully answered. They really haven't been processed yet. I know that, for instance, medical directorship in big hospital systems here are thinking about this and trying to figure it all out. I have nothing that's come my way as of yet to say any of this has been fully discerned. A quick maybe comment from Misty Smith, Lauren Heath from the university with regards to what they're aware of maybe going on there, if there's anything different than what I've learned so far.
I'll defer to Lauren because she's more on the clinical side.
I'm not fully plugged into these issues, so I don't have any additional insight beyond what Dr. Fine shared, but I share your concerns, Dr. Viner, and think that's an important issue for everyone to work to address.
Yeah, so more questions than answers. Go ahead, Misty, then we'll.
If I can add, it is a component that we're addressing in the pharmacology education aspect of it. So those conversations are in progress.
Great. A lot of clinical issues that have yet to even begun to be untangled with all of this, as well as administrative issues, how MAR works and how, anyway, it's very, a lot of moving parts. I will bring this meeting to a conclusion, 11:02 a.m. Mountain Time. Thank you all. We've covered an extraordinary amount of material. Thank you all for your concerted efforts, your concentration. Again, Dr. Carlson and Dr. McGiff for taking over. I will eagerly look forward to working with you over the next year to whatever extent I can. And Rich, Sarah, and Sarah, we have a plethora of Sarahs. Just Godspeed, everybody. Take care. We'll see you in July.
See y'all later.
Everyone.